Lecture 41, The Treatment of Mental Illness. The diathesis stress model for understanding the origins of mental illness offers a framework for understanding their treatment and prevention as well. If mental illness is caused by the interaction of diathesis and stress, then effective interactions should alter the diathesis factors, the stress factors, or ideally both. The first goal of any medical treatment is to achieve a cure. Genuine cures will do more than suppress superficial symptoms. They will eliminate the underlying disease, or reduce it to a clinically significant extent, returning the patient's level of functioning to what's known as within normal limits, even after active treatment has stopped. In the absence of a cure, treatment focuses on the amelioration of symptoms, or rehabilitation regimes that permit the patient to cope with a chronic condition. Now, I said earlier that the first goal of medical treatment is to achieve a cure, and invoking the term medicine might suggest that I have in mind biological treatments. But you'll recall that the medical model doesn't imply either a medical cause, a biological cause of mental illness, or a biological treatment. All the medical model assumes is that mental illness is the product of natural causes that can be understood by science, whether it's biological science or social science or psychological science. And similarly, there is no implication that the treatments have to be biological in nature. They just have to be based on scientific theory and supported by scientific evidence. In fact, the treatment of mental illness comes in three basic forms. Up until the 20th century, there were really no active treatments available for mental illness, so intervention focused largely on custodial care, chiefly the warehousing of the mentally ill in private asylums or state mental hospitals. Beginning in the late 19th century, various forms of psychotherapy were introduced. These interventions, one way or another, were intended to alter the patient's pathological mental states, their abnormal beliefs and feelings and desires, which were thought to underlie the various symptoms of mental illness. By changing these abnormal, maladaptive mental states, mental health professionals sought to change the maladaptive patterns of behavior that brought patients to the attention of the professionals in the first place. Beginning in the 20th century, a wide variety of biological treatments were introduced for mental illness. These began with procedures like electroconvulsive therapy and even psychosurgery, where physicians operated on various brain centers that were presumed to be implicated in the patient's problems. But more recently, a wide variety of medications have been introduced for the treatment of various mental illnesses, beginning with schizophrenia. These medications have largely supplanted psychosurgery and ECT, though both still have a place in selected cases. For example, a variety of antipsychotic medications, that's what they're called, are used in the treatment of schizophrenia. These include drugs called phenothiazines, which alter dopamine levels in the brain. Common trade names for phenothiazine class drugs are thorazine, stelazine, prolixin, and mellaril. Now, you don't have to know all these drug names or even all these trade names, but I'd like you to be able to recognize the basic trade names when you see them in newspaper and magazine advertisements, for example. And as with our discussion of neurotransmitters and synaptic transmission early in the semester, you don't have to know the pharmacological details either, just the broad brushstrokes. To be honest, most of the drugs used in the treatment of schizophrenia, phenothiazines like thorazine and other drugs like Haldol, are really nothing more than major tranquilizers, which calm the patient, reducing the tendency to report and act on hallucinations, if not to have them. This is also true of the so-called atypical antipsychotics like Clozaril. Atypical because they're not a typical tranquilizer. But nobody, not the manufacturers, not the psychiatrists who prescribe them, thinks that they act directly on the patient's underlying pathology. However, these drugs do make patients more manageable, and their introduction has made everybody's life better, staff and patients inside mental hospitals and outside, and made it possible for many people with schizophrenia to be released from mental hospitals to live with their families or elsewhere in the community. But as with many psychiatric drugs, you've got to keep taking them. And the problem is that once released from direct supervision in a hospital or halfway house, this is something that many schizophrenic patients just aren't inclined to do. A major advance in the treatment of depression came with the introduction of the so-called tricyclic antidepressants. Drugs like tofranil and Elavil and Sinequan, which increase levels of norepinephrine and serotonin at the synapse. A second generation of drug treatments for depression came in the form of so-called MAO inhibitors like Nardil or Parnate. As their name implies, these drugs act to inhibit a substance, monoamine oxidase, MAO, which has the effect of deactivating norepinephrine and serotonin. So either way, whether you use tricyclic antidepressants like tofranil or MAO inhibitors like Nardil, you're effectively increasing the availability of norepinephrine and serotonin to these two neurotransmitters at the synapse. Yet a third generation of drug treatments for depression is found in the selective serotonin reuptake inhibitors, drugs like Prozac and Zoloft, Paxil, and Celexa. These drugs act selectively on serotonin, not norepinephrine, and they do it by inhibiting the reuptake of serotonin by the presynaptic neuron. Again, the effect of this is to make more serotonin available at the synapse. The drug treatment of anxiety disorder also focused on sedatives, such as the barbiturates, such as Nembutal, the propranodiols, like Miltown, and the benzodiazepines, such as Librium, Valium, and Xanax. These benzodiazepines have been especially popular in the treatment of anxiety. The 20th century was known as the Age of Anxiety, and popular literature and movies concerned with the American middle class in the 1950s and 1960s are full of references to these drugs. Now, as it happens, there's a degree of comorbidity between anxiety and depression. Comorbidity is a medical term referring to diseases that tend to go together, and people who are anxious tend also to be depressed and vice versa. For that reason, anxiety disorder is sometimes treated with selective serotonin reuptake inhibitors such as Paxil. And Paxil has in fact been shown to be effective in the treatment of anxiety, though it's not clear exactly how that works. Maybe it merely helps patients feel less depressed about being anxious. There are also some so-called atypical anxiolytics, such as Buspar. Anxiolytic is a fancy medical term for anti-anxiety agent. And, much after the fashion of the atypical antipsychotics, Buspar and other atypical anxiolytics are not just sedatives. They're something else. They're another pharmacological class of drug entirely. The introduction and effectiveness of these drugs has led to what many have called a pharmaceutical revolution in mental health. And in some ways, drugs have become the most popular treatments for mental illness, certainly the most popular biological treatments for mental illness. They afford those who take them a considerable amount of symptom relief. Schizophrenics are no longer as bothered by their hallucinations. Depressives are no longer as depressed. The anxious are no longer as anxious. They work in that sense. And as I said before, the availability of these drugs has permitted a tremendous amount of deinstitutionalization. They've allowed many mentally ill patients to be released from mental hospitals and allowed to return to their families and their communities. And that's generally a good thing. In many instances, these drug treatments have been developed based on specific somatogenic theories of the illness in question. In theory, at least, The psychiatric medications work because they address the biological bases of mental illness. Thus, according to the dopamine hypothesis of schizophrenia, drugs that alter the processing of dopamine should be effective treatments for schizophrenia, but not for depression. And according to the monoamine hypothesis of depression, drugs that alter the processing of monoamine neurotransmitters should be effective treatments for depression, but not for schizophrenia. And so, of course, they are. So prescribing these drugs does make theoretical sense. Same thing goes for the anxiety disorders, because the benzodiazepines and other sedative drugs have their pharmacological action on a particular neurotransmitter, GABA, that is thought to be implicated in anxiety. The selective serotonin reuptake inhibitors, the SSRIs, which act specifically to enhance the availability of a specific neurotransmitter, serotonin, in depressed patients, are perhaps the clearest expression of this connection between theory and treatment. In all these cases, especially for depression and anxiety, the theory is that these drugs are attacking the biological bases of the psychopathology. But sometimes drug treatments are simply empirical, meaning that they're prescribed simply because they're known to help, and not because their efficacy is predicted by any theory of the illness in question. One example of such an empirical treatment is lithium carbonate, which is often prescribed for bipolar disorder, so-called manic depressive illness, and in fact is very effective. Treatment with lithium can reduce or eliminate episodes of mania in as many as 70% of cases, and also reduces episodes of depression. In that sense, it's a very effective treatment for bipolar disorder. But we have no idea really how it works, and the fact that it should work wasn't predicted by any biological theory of bipolar disorder. Rather, physicians were using lithium in the treatment of some other illness, and they simply noticed that as a side effect, lithium tended to stabilize people's moods, and it occurred to them that maybe it would work for bipolar disorder as well, and so it does. Another example of an empirical treatment is the prescription of amphetamine-related drugs such as Ritalin for the treatment of attention deficit hyperactivity disorder. There is no good reason why Ritalin should work in these cases. Given that amphetamine is a central nervous stimulant, there'd be every good reason to think that giving Ritalin to somebody with attention deficit and hyperactivity would make things worse. But it doesn't. As an empirical matter, it makes things better for large numbers of children, adolescents, and even adults who are diagnosed with attention deficit hyperactivity disorder. Ritalin is now approved for the treatment of ADHD, but there's still no theory that explains its paradoxical effects. One theory is that amphetamines activate brain centers that are involved in the control of attention, which are relatively inactive in patients with ADHD. It's a good hypothesis, but it's just a hypothesis, and frankly a rather post hoc hypothesis at that, and as yet there's no evidence supporting it. But again, there is evidence supporting the effectiveness of Ritalin in the treatment of ADHD. The pharmaceutical revolution in mental health has been a genuine revolution, providing a degree of symptom relief that simply was not available to patients previously, and enabling the deinstitutionalization of large numbers of patients from mental hospitals, which offered mostly custodial care, back to their homes and into the community. And it's also improved the lives of a large number of individuals who are being treated on an outpatient basis by psychiatrists, clinical psychologists, and other mental health professionals. At the same time, pharmacotherapy for mental illness has some problems. The first of these is that many of these medications have undesirable side effects, such as the Parkinsonism, mimicking the motor symptoms of Parkinson's disease, and tardive dyskinesia, difficulties with motor control that frequently accompany the use of antipsychotic medications. Other side effects include dry mouth, which many psychiatric patients complain of after they've started on a regimen of drugs. It's not life-threatening, to be sure, but it can be annoying. There's also a certain lack of specificity in the actions of such drugs, such as when Paxil, a selective serotonin reuptake inhibitor, which ought to be useful for depression, is used to treat anxiety as well. Along these same lines, there is good evidence that the effects of many psychiatric drugs, including the SSRIs, are heavily loaded with placebo effects. That is, an effect that you'd get simply by taking a sugar pill or a pill with some other inert substance in it. According to one estimate, fully 75% of the effect of antidepressant medication is attributable to placebo, rather than to any specific pharmacological action. Now, of course, none of this means that these medications are just placebo effects. They're more effective than placebo. But the fact that there's such a strong placebo component in many of these medications bothers some practitioners quite a bit. Finally, psychiatric drugs provide symptom relief, but they don't provide anything like a cure in the sense of reversing underlying biological processes or psychological deficits. Patients whose mental illness is effectively controlled while they're on medication will typically relapse if their medication is discontinued. Perhaps the most important consequence of the pharmaceutical revolution in mental health has been to give practitioners and therapists a means of managing chronic mental illness. In this way, the pharmacological treatment of schizophrenia, depression, anxiety disorder is analogous to the use of insulin to treat diabetes. Patients with schizophrenia will still have schizophrenia, and patients with depression will still have depression. But with medication, they can better deal with their illnesses and lead more productive lives. That's a non-trivial benefit. But genuine cures for mental illness are going to have to wait for further pharmaceutical advances, or perhaps another approach entirely. Now, pharmacotherapy, the use of drugs in the treatment of mental illness, is a relatively new approach to treatment. Historically, the active treatment of mental illness was limited to various forms of psychotherapy, the talking cure, in which a therapist engaged in activities that were intended to alter the contents of the patient's mind, to change the patient's beliefs, feelings, and desires, and thus his or her behavior. Although there were important precursors, the birth of psychotherapy is given commonly as 1893, when Sigmund Freud and Joseph Breuer began publishing the articles that were eventually collected as their Studies on Hysteria. In their book, Breuer and Freud famously asserted that hysterics suffer from reminiscences. That is to say, that individuals with hysteria had suffered some kind of psychological trauma, which they had repressed, pushed out of consciousness, and couldn't remember. But this traumatic memory remained available in memory and caused the hysterical patients to suffer the symptoms that they suffered, blindness, paralysis, whatever. The goal of psychotherapy for Breuer and Freud was to get patients to consciously remember these traumatic events, bring them into awareness so that they could cope with them consciously, recognize them for what they are, and deal with them. Now, it's not at all clear that this was really the right way to think about hysteria, but that's another matter. The point for Breuer and Freud was that hysteria wasn't caused by some problem in the patient's brain, it was caused by a problem in the patient's mind, that they had these memories that were repressed and were causing them problems. So the goal of treatment was to get the patient to remember, to acknowledge, and to cope. Now, it's not at all clear that this is, in fact, the right way to think about what causes hysteria, or what we now think of as the dissociative disorders. And, for that matter, there's no evidence that Breuer and Freud's treatment was particularly effective with these patients. That's not what's important. The important point is that Breuer and Freud, instead of thinking about operating on patients' brains, thought about operating on patients' minds, getting them to acknowledge and reflect on their feelings and beliefs and desires, encouraging them to think about things in new ways, and through this essentially educational process help their patients to lead better, more fulfilling, more productive, happier lives. All psychotherapy has this goal. All psychotherapy works just this way. Let me just reinforce this point very briefly. As a treatment for mental illness, pharmacotherapy attempts to alter the mind indirectly by altering the chemistry of the brain. By contrast, psychotherapy attempts to alter the mind directly by arranging learning experiences that change how the patient thinks and feels and desires and behaves. Pharmacotherapy and psychotherapy have the same goals, to change the patient's behavior, but they take two quite different routes, one an indirect route, the other a direct route, to that end. Again, there are literally hundreds of different forms of psychotherapy, not just the classical psychoanalysis associated with Sigmund Freud, but they can all be classified under three major headings. Psychodynamic, insight-oriented psychotherapy, such as Freudian psychoanalysis, is the oldest of these different kinds of psychotherapy. In this technique, the therapist helps the patient to gain insight into unconscious conflicts that presumably lie at the root of his or her symptoms. For Freud, these conflicts involved primitive, unconscious sexual and aggressive urges, which gave rise to anxiety, which the patient reduced by engaging in repression and other psychological defenses, which in turn caused various symptoms to occur. Hysterics suffer from reminiscences. Psychoanalysis was intended to help the patient become aware of these conflicts and to acknowledge his primitive urges so that the defenses would no longer be needed and the symptoms would disappear. So-called neo-Freudian psychoanalysis retained the emphasis on unconscious conflict, but de-emphasized biological drives having to do with sex and aggression, and focused instead on the conflicts the patient encountered in the real world. Classical psychoanalysis was a 5 times a week affair. Freud even vacationed with his patients. What is known as psychoanalytic psychotherapy is less intense, but follows much the same rationale as the classic form. Perhaps the most popular form of neo-Freudian psychodynamic psychotherapy in use today is so-called interpersonal therapy. Here the focus is on the patient's understanding and changing his relationships with other people in the real world, but the patient's current interpersonal relationships are connected to early interpersonal relationships with his or her parents. So interpersonal therapy, in a sense, has one foot firmly planted in the real world of the adult patient and the other foot planted in the imagined world of the young child. A leader in the development of neo-Freudian psychoanalysis was Sigmund Freud's own daughter, Anna. These days, psychodynamic psychotherapy often takes the form of interpersonal therapy, a technique introduced by Harry Stack Sullivan. Behavior therapy was introduced in the 1950s by Joseph Volpe as a behavioristic reaction to the mentalism of psychoanalysis. Rather than resolving the unconscious conflicts that supposedly underlay the patient's symptoms, behavior therapists sought to modify the symptoms themselves directly by means of techniques derived from classical learning theory. From their point of view, symptoms weren't caused by disease. Rather, the symptoms were the disease. In some cases, such as phobias and obsessive-compulsive behaviors, the assumption was that the symptoms were learned behaviors that could be unlearned. But even if the symptoms were not acquired through learning, it was assumed that they could be modified by learning. For that reason, some forms of behavior therapy were called behavior modification. Later, in the aftermath of the cognitive revolution in psychology, behavior therapy was supplanted by cognitive therapy, which attempted to alter the patient's behaviors, whether overt behaviors or covert behaviors, by changing the patient's cognitions. Early proponents of cognitive therapy were Albert Ellis, who developed what he called rational emotive psychotherapy, which encourage patients to think rationally about their emotional feelings, and Aaron Beck, who introduced cognitive therapy as a result of his work on the cognitive theory of depression. You'll remember that Beck argued that depression was caused by a particular way of thinking, what he called the depressogenic schemata, negative views of self, negative views of the world, and negative expectations of the future. So Beck organized his therapeutic sessions around the goal of changing those thoughts, and by changing the way the patient thinks about the world, changing the way the person feels. In 2006, Aaron Beck received the prestigious Lasker Award for clinical research, the first ever given to a psychiatrist for research on treatment. The chairman of the award jury noted that cognitive therapy is one of the most important advances, if not the most important advance, in the treatment of mental diseases in the last 50 years. Even with the new mentalism represented by cognitive psychology, the goal of cognitive therapy is to change the patient's behavior. So the hybrid term cognitive behavioral therapy, or CBT, has become popular. Whereas psychodynamic therapy focuses on the patient's past, especially his childhood, cognitive behavioral therapy focuses on the here and now of the patient's life. Humanistic psychotherapy emerged as a reaction to both psychoanalysis and behavior therapy. In both kinds of therapy, the therapist was extremely directive, either in keeping the patient focused on unconscious conflicts or teaching the patient new ways of behaving. Viktor Frankl, an Austrian psychiatrist who had been incarcerated in Hitler's concentration camps during World War II, introduced what he called existential therapy, intended to guide people in their search for the meaning of life. Carl Rogers introduced a client-centered therapy in which the patient sets the therapeutic agenda, and the therapist merely helps create an environment of unconditional positive regard in which the patient can achieve self-actualization, a term introduced by another humanistic psychologist, Abraham Maslow. Rogers' language is very revealing here. Patients are the passive recipients of the action of agents, but clients hire people, like lawyers, to work for them. In both psychodynamic and cognitive behavioral therapy, the agenda is set by the therapist. In humanistic therapy, the agenda is set by the client. Of all the various forms of psychotherapy, the cognitive behavioral therapies are most closely tied to the kind of scientific analysis of mind and behavior that we've been pursuing in this course. Cognitive behavioral therapy was first introduced for the treatment of anxiety disorders, especially phobias and obsessive-compulsive disorder. Among the most popular techniques of CBT are systematic desensitization and flooding. Systematic desensitization involves a progressive, graded exposure to a phobic stimulus like a snake or heights or the dark. Flooding, also known as implosion therapy, has the patient immediately immersed in the most frightening situation, either direct contact with the phobic object, or rehearsal of an obsessive thought, or the prevention of a compulsive behavior. In both cases, the patient can experience complete alleviation of anxiety, which will never return, the very definition of a cure, through the extinction of fear, aversion, or other response, and the acquisition of more appropriate adaptive behaviors. In the treatment of phobias, systematic desensitization and flooding are equally effective. Flooding is more efficient, but it's also somewhat more dangerous. If done improperly, the patient will be left worse off than when he started. So don't try this at home. Some forms of mental illness, particularly the anxiety disorders, depression, and the delusions of schizophrenia and bipolar disorder, appear to reflect maladaptive knowledge or belief acquired through social learning. According to Beck's cognitive theory, depression is caused by a particular set of beliefs, as well as a cognitive style that maintains those beliefs. Similarly, following the learned helplessness model of Seligman, depression may be caused by the patient's belief that important, particularly aversive events, are uncontrollable. Anxiety may be caused by the patient's belief that such events are unpredictable. And delusions may reflect the patient's inappropriate attempts to explain the anomalous experiences associated with schizophrenia and the manic-depressive mood swings of bipolar disorder. In these cases, the goal of cognitive therapy is to change the patient's underlying cognitive structures, or schemata. The cognitive therapist may confront the patient with schema-incongruent information that will stimulate schema change, information that can't be assimilated into the schema and that forces the schema to accommodate to the new information. The therapist will also provide a more adaptive way of construing the patient, him or herself, other people, various social situations, and the past, the present, and the future. The therapist will help the patient change his or her interpretation of the situation and construal of experience, and also help the patient alter his or her expectations of the future. Beck's cognitive therapy for depression entails altering the patient's depressogenic schemata, the depressogenic triad of negative beliefs concerning oneself, the world, and the future. Cognitive therapy also seeks to alter the patient's tendency toward arbitrary inference, selective abstraction, overgeneralization from experience, magnification of single events, and minimization of positive events that maintain these schemata once established. And based on the learned helplessness theory of depression, Seligman, Abramson, Alloy, and their colleagues have suggested that depression may be alleviated by changing the individual's depressogenic attributional style that leads him to form feelings of helplessness and hopelessness, thus enabling the patient to make more realistic, adaptive causal attributions about various events. For the psychophysiological or psychosomatic disorders, theoretically anyway, the best treatment would be to eliminate the stressor from the patient's environment. However, this is not always possible, in which case the treatment involves modifying the patient's response, including physiological responses mediated by the autonomic nervous system. Relaxation training seeks to achieve a general reduction in the patient's emotional reaction to the stressor, essentially modulating the general adaptation syndrome that we discussed in our lectures on the biological bases of mind and behavior. Meditation training, whether transcendental meditation or mindfulness meditation, seeks to accomplish the same kind of goal. Relaxation training focuses on autonomic and skeletal responses to stress. Meditation seeks to calm the body by calming the mind. Biofeedback training permits the patient to gain some voluntary control over the functioning of some elements of the autonomic nervous system, such as heart rate or blood pressure. Because autonomic nervous system activity is not generally accessible to conscious awareness, you have no idea what your blood pressure is unless you measure it, the therapist must use special physiological monitoring devices, such as the electromyogram for muscle tension or the electrocardiogram for heart rate activity, to provide information to the patient about his or her internal physiological state. In biofeedback, an electronic apparatus signals the patient's level of physiological activity, and the patient learns, through a process similar to instrumental conditioning, to control his or her own internal physiological state. Many behavioral disorders and those annoying little problems in living often result from the individual's inadequate social skills. Public speaking anxiety, for example, while not necessarily rising to the level of a full-fledged social phobia, can be extremely debilitating, but can be relieved simply by giving the person practice in public speaking in a controlled, friendly environment. Many people have a great deal of trouble saying no to other people, including their parents or their children or spouses. In this case, assertiveness training can help people can make and respond to demands more adaptively. And people's sexual problems are not limited to impotence or frigidity. Often the difficulties that people have in maintaining sexual arousal or achieving orgasm in oneself or in one's partner, reflects a simple lack of knowledge about how to make love. Sex is a biological function and in that sense natural, but the pleasure-giving and pleasure-receiving aspects of lovemaking don't come naturally. Many people learn to make love through practice, but many people need instruction in the form of sex therapy, not necessarily from a sexual surrogate, but sometimes just some friendly advice. Now, the notion of psychotherapy is fine in principle, and it's made a healthy living for several generations of psychiatrists, clinical psychologists, and other mental health professionals. But does it really work? Psychotherapy has been plagued from the beginning by what might be called the Woody Allen bugaboo, after the characters played by the actor-director, who often go through years, decades of psychoanalysis but never seem to change. In fact, psychotherapy came to a crisis in the early 1950s when Hans Eysenck, a British psychologist, reviewed the literature and claimed that psychotherapy was simply ineffective, that people who received psychotherapy had no better outcomes than those who received no treatment at all. It was just about this time that the pharmaceutical revolution began in the treatment of mental illness. The evident success of these drugs, combined with negative reviews such as Eysenck's, put traditional psychotherapists on the defensive. They were challenged to demonstrate scientifically that psychotherapy really helps people with mental illness. In fact, since Eysenck's original study, a large body of empirical research has attempted to put the question of the effectiveness of psychotherapy to a test. This movement to demonstrate the effectiveness of psychotherapy is part of a larger movement in healthcare called evidence-based medicine, or evidence-based practice. Stimulated partly by insurance companies, partly by government agencies, and partly simply by consumer demand, healthcare providers of all sorts have been challenged to show that what they do actually works. And psychotherapists have not been immune from these pressures. To some extent, research on the effectiveness of psychotherapy is modeled on drug research, where drug manufacturers have to show that a new drug does better than a placebo or a traditional drug or some other standard of care before it can be marketed for a particular purpose. The drugs are evaluated objectively with a quantitative assessment of whether and to what extent the patient gets better. The same thing goes for psychotherapy research. Patients are randomly assigned to a group that receives a form of psychotherapy or another group that receives no treatment at all, or perhaps a placebo treatment. The outcomes of the treatment are evaluated objectively and quantitatively, and a treatment is declared effective if the people who receive it show significantly better outcomes than those who do not. Of course, this is just a variant on standard experimental design. In fact, a classic review of psychotherapy outcome studies by Smith and his colleagues combined the results of a large number of studies that compared adult patients who received various forms of psychotherapy to control patients who went untreated. Typically, the control patients were not actually denied treatment, but were merely put on a waiting list until a therapist became available. So the question is, given X number of months or years since their diagnosis, have patients who received psychotherapy improved more than those who did not? And the answer is yes. In the Smith et al. Analysis, the median patient who received psychotherapy did better than about 75% of the control patients. And this was true pretty much regardless of the form of therapy that was being assessed. The median patient who received psychotherapy did better than about 75% of the control patients who did not. And that's objective, quantitative evidence that psychotherapy really does work after all. The fact that patients who received psychotherapy did better than those who did not, regardless of what form of therapy that they received, led some commentators to conclude that all forms of therapy are essentially equivalent. It doesn't matter what the therapist does, so long as the patient sees one. Lester Luborsky, a psychoanalyst who's a prominent psychotherapy researcher, has labeled this point of view the dodo bird verdict, after an episode in Lewis Carroll's Alice's Adventures in Wonderland. In this episode, the dodo bird organized a caucus race, in which the animals ran around until they ran out of breath and stopped. When Alice asked who had won, the dodo bird replied, "Everyone has won, and all must have prizes." The dodo bird verdict has been a source of comfort to some psychotherapists who prefer to use those psychodynamic forms of therapy that have come under attack by modern scientific psychology, as well as those who believe that the therapeutic relationship between therapist and patient is more important than anything that the therapist does, also a view derived from psychodynamic psychotherapy. But the dodo bird verdict is troubling too, because it suggests that the effects of psychotherapy are nonspecific. That is, that there's no particular active ingredient that makes some form of therapy effective. Put another way, it suggests that psychotherapy is simply a kind of placebo. And since psychiatric medications are approved for use precisely because they have been shown to be better than placebo, this suggests that psychotherapy might be ineffective after all, or at least inferior to pharmacotherapy. But is it really true? Fortunately, the Smith study contained an analysis that actually showed that the dodo bird verdict is not quite right. Some psychotherapies really work better than others. They computed a statistic known as the effect size for each of the studies included in their analysis. The effect size is a measure of the difference in mean outcomes between two treatments expressed in standard deviation units. So an effect size of 1.0 means that the average subject in the experimental group scored one standard deviation higher than the average subject in the control group. In behavioral and social science research, we classify an effect size of 0.20, 1/5 of a standard deviation, as a small effect, an effect size of 0.50, half a standard deviation, as a moderate effect, and an effect size of 0.80, 4/5 of a standard deviation, as a large effect. When Smith and his colleagues calculated the average effect size for different types of therapies, all forms of therapy were shown to have at least moderate-sized effects, and that's consistent with the dodo bird verdict. However, the effect sizes associated with the cognitive and behavioral therapies were much larger than those associated with the psychodynamic and humanistic forms of treatment. All of these effect sizes are large, but the effect sizes associated with cognitive, behavioral, and cognitive therapies, by the standards of behavioral and social science research, they're enormous. Similar results were obtained in another analysis reviewing the outcomes of psychotherapy for children and adolescents. The non-behavioral treatments, like psychodynamic therapy, did okay, but the behavioral treatments did much, much better. So it's not really true. Based on these studies and others like them performed since, it appears that all psychotherapies are not created equal. As a rule, cognitive and behavioral therapies are more effective than psychodynamic and humanistic therapies. Other considerations also suggest that the dodo bird verdict is not right. For specific illnesses, some forms of therapy have got to be more effective than others. In general, the cognitive and behavioral disorders are more effective than insight-oriented therapies in the treatment of a wide variety of mental illnesses, especially the anxiety disorders. But it may very well be that psychodynamic kinds of therapy are particularly good for some forms of mental illness. One size does not fit all. Still, by and large, the cognitive behavioral therapies seem to be more efficient than the insight therapies in that they achieve their positive results in less time and therefore with less expense to the patient. For this reason, cognitive behavioral treatments are quickly emerging as the standard of care in the psychological treatment of mental illness, behavioral disorders, and other problems in living. Now, if pharmacotherapy is effective and psychotherapy is effective, what about the combination of the two? Research of this sort is just beginning to emerge, but the results so far are quite promising. In one study, for example, depressed patients who received cognitive behavioral therapy did about as well as those who received Serzone, a selective serotonin reuptake inhibitor, but those who received both the therapy and the drugs did especially well. More patients who received the combined treatment showed satisfactory progress, and many more patients in the combined group showed complete remission of their depressive symptoms. This was true both at the end of treatment and also on follow-up 12 weeks after the drugs had been discontinued and the psychotherapy had been terminated. Patients in the combination group showed better outcome, and that outcome lasted. This is probably as it should be. The presently available psychiatric drugs offer a fair measure of symptom relief, but not a cure. Psychotherapy gives the patient the knowledge and skills to overcome his illness, or at least to cope with it more effectively. In the study I just described, patients who got the Serzone, the SSRI drug, experienced a temporary boost in their mood, and that's not a trivial outcome. But patients who got active psychotherapy learned to deal with their depression on an ongoing basis and to adjust to the life after the depression goes away. Patients can suffer relapses when their drugs are withdrawn, but in a sense, new knowledge and skills acquired through the experience of cognitive behavioral therapy never go away. They remain permanently available to the patient as part of his or her repertoire of social intelligence. You can think of the old proverb, "Give a man a fish, and he eats for a day. Teach a man to fish, and he eats for a lifetime." Giving a patient drugs is like giving a man a fish. When the drugs are gone, they're gone. But the learning that comes through active cognitive behavioral psychotherapy stays forever as a permanent resource for the patient.